obligation and responsibilities not only to the patient, but for the patient to us as well. It has to be a two-way relationship. And this that can only come if we engage them as a part of the care team. And most of you have heard of ERAS. And basically, what is ERAS? ERAS is really education and getting the patient as part of your team. So we all know a professional is someone who can trust the right thing when no one is looking. And they use a judicious use of communication, knowledge, clinical reasoning, emotional values and reflection, and obviously not forgetting the technical skills. Very important. The journal manuscript that we were handling at that time was just about 200, just over 200. And by the end now, we're handling about 1,200, 1,200 manuscripts are being handled every year. So that's quite a six-fold increase. The number of new submissions has also increased. In 2014, it was 145. Now almost 980 new manuscripts that are submitted. And based on this volume, we changed the architecture and the structure of the editorial board, where we now have we haven't had an associate editor, but we've added section editors. So then the amount of work that needs to be done, the outreach that needs to be done, so that has really helped us as well. Now, if you look at it from 2015 onwards, we've done a total of 1,270 items have been published. This journal was primarily review articles and meta-analysis. That was a very sort of narrow focus, so we went ahead and increased the scope of the journal. So we included multimedia, original research, editorials, all sort of types of manuscript. And as you can see, over this 12 years, vast proportion are actually original research. And about 260 reviews. This is all based on the growth that was seen. And so our scope really did work. One of the issues that we really had initially was we could not get our manuscript reviewed. We really had a sort of disengaged reviewer pool. And to show that we have a very robust, and this is important for PubMed indexing as well, and it's very important so that we can have manuscript processed in a timely fashion, and to ensure to the entities that there's a robust peer review system. So when we went from an approximately, we had about 300, when I started, about 300 reviewers that were truly engaged, and now we're well over 1,500 we have in our database that we can access. We used to have trouble getting at least 2 or 3, and now we have no trouble getting 2 or 3 different reviews for each individual article, and sort of a fair amount of effort on my part in really developing a relationship with the reviewers and really get them engaged. And as part of Elsevier, what they do is they really have a database of engaged reviewers who basically invite them, they say yes, and that has gone from 50 to 360 over this time frame. And so that has really improved our peer review. The turnaround time, so the time that they submit and you get the first decision, we were in the region of 60 days when I first started, and now we're down to 21 days. And that's, authors like it, okay, and good metric for comparison, and that helps with increasing the number of submissions as well, because nowadays authors, they have a lot of choice. It's no longer that we have to have papers, 6 copies of that, hard copy and printed material sent. No, it's all electronic. And what we've done in addition is that we partnered with a lot of other journals through Elsevier, that if I think that it's not suitable, we will maneuver it into another sister journal. Citation, impact factor at the bottom line, that's the bottom line. What is our impact factor for the journal? And for that means, how many citable items are you publishing? So when I started, we only had about 29 citable, and we've now gone up to 386 items. So with the increase in volume, but also increasing the citation, our impact factor really sort of didn't go down, but because with a publication of almost 1,270 items, you'd expect that the impact factor would have fallen, well down to 0.5, and it did not happen. In fact, it increased to 3.5. You reduce anxiety, improve communication, and build a trust, and thus encourage patient engagement and also improvement. So hear a lot about in India that it's very transactional, and you put your my own aunt, she needed a neurosurgical procedure, and they called me and I said, yes. Did you talk to the surgeon? He said no. You have to put 1 lakh. And pay that before he'll even talk with you. So it was really nice to see this, that they are sort of saying this is inculcating into a new generation. So as you had mentioned that ACGME, the 6 competencies, we move towards competency-based training and professionalism is a very important component.
Rest of the faculty probably will come in slowly. I just have a small announcement, but maybe I'll make it later. I think let's move on to the second half of the session on professional empathy. First half was quite interactive, and I think that interaction was just made possible because all of our speakers delivered the lectures and completed well before time. And that gave us a good amount of time to do some discussions. And I request all the speakers to see if they can finish within the allocated time, and that would give us a good space to do discussions as a group. So moving on, without further ado, let me invite Professor Supakon Rojanin. And Prof is a dean. He is a breast surgeon by training. He is the dean of medical school at Chiang Rai, Thailand, and he's also a former chairman of the Department of Surgery. He will be talking today on the topic of fostering empathetic support to surgeons in practice and training, the perspective he brings from Philippines. Over to you, Prof. Thank you.
Yes,
Thailand. Sorry, Thailand.
Okay, thank you very much for inviting me to speak in something that in the future as AI and surgical intervention. At my age, when I was a resident, physical examination, sign and symptom is a major role for detection, diagnosis, treatment, and prognosis in surgical cases. But nowadays, people use AI to replace the sign and symptom and physical examination, and they put them in the library where people seldom go to visit. Yes. In 20 years ago, when quality assurance was established, in Royal College of Surgeons of Thailand, established the good surgical practice. This is a special course compulsory for every trainer have to join, otherwise they cannot pass or get the examination, final examination of the training. So at that time we have, in surgical care, we need 3 standards. The standard of competency. To cure the patient, you need to have the knowledge, skill, experience, decision making, and CME, and the standard of care for patient safety, and then the standard of conduct to make trust for the patient, not only for patient but also for your colleagues and your family as well. At that time, we set up the 10 commitment for patient safety from emergency response to discharge planning that all the surgeons have to do in 10 commitment in patient safety like that. And we also have the 10 commitment for ethical practice. That is from yourself in the communication to the other, to maintain moral for trustiness to the patient, relative, and professional colleagues. At that time, the empathy is a small jigsaw for us because we stressed on compassion. Empathy means understanding and action. In surgery, we apply to all that you can already know that, and the patient don't care how much you know until they know how much you care to the patient. Now, at present, we use AI and surgical innovation in many aspects. We use the AI tool from the hospital administration, in medicine, or in surgery, but we will not go into detail of each such AI tool and individual private company. However, AI tool used in medical services and surgery, we can use in the medical services, in clinical decision and support system, and patient management and hospital workflow. And also we use the virtual health assistant for education. In surgery, now we use the robotic surgery platform and AI assistant. AI-based surgical planning tool in brain, in orthopedics, in cardiac surgery. Intraoperative guidance, imaging AI for detection of the small cancer like that, and predictive analytic for surgery to predict the risk, outcome, and complications. So AI tool have many benefits. It can reduce time, administrative burden, enhance telecommunications. It also supports the diagnosis, prognosis, decision-making, and investigation.
It is a critical, non-negotiable component of effective surgical care. So the surgeon needs to display some passion in engaging with a patient. Now let's examine the situation in Africa. Africa is a landscape of challenges and resilience.
Empathy means understanding and action. In surgery, we apply to all that you can already know that, and the patient don't care how much you know until they know how much you care to the patient. Now, at present, we use AI and surgical innovation in many aspects. We use the AI tool from the hospital administration, in medicine, or in surgery, but we will not go into detail of each such AI tool and individual private company.
On behalf of the organizing committee and ICS World Body, myself, Vishal, I'm one of the members within the organizing team. Welcome you all today and hope you have a good time. Congress will be starting tomorrow, but today pre-Congress we had workshop, and this is a half-day session on something which I am very passionate about with regards to the non-technical aspects of the surgery in the era of innovation and artificial intelligence. So with that ethos, I welcome everybody for this session, which I feel is quite I would consider this as not like a landmark or so, but quite an essential session for all of us on professional empathy. It's my privilege to welcome you all here at the 44th International College of Surgeons meeting in Singapore. We meet to discuss something that transcends technology as well as the global geographical barriers, where we articulate a value that is very much sacrosanct to our profession and is urgently need to reignite within the profession, and that's the value of empathy. So today we'll, on behalf of organizing team, will go on something called as Declaration on the Professional Empathy for Surgeons, and I've crafted a document over many months which have been shaped by conversations with many of you and many of us who are not present in this room and who represent ICS world body. The declaration will stand on 3 pillars. It reaffirms empathy as a virtue in surgical practice, a response to the contemporary pressures within the surgical fraternity, including AI, burnout, and so on. It also charts a forward-looking commitment to embed empathy into the surgical identity, education, leadership, and the systems thinking. So it's an ethical charter, a cultural commitment, and a professional voice. We live in the era of AI, where AI is writing clinical notes, taking down conversations of doctor-patient. Robots are tying the knots in the operating field, and apps are telling us and reminding us that we should be washing our hands. Yet none of them can replace the human touch which we can deliver and which most of patients desire of. So this declaration reminds us that empathy is not only an afterthought, but is inculcated in the clinical behavior and is a professional responsibility, and I would even say quality metric of our soul. So it tells us it's not merely a strongly expressed wish, but it's something which is lived. So in that setting, Singapore, I think, is at the interface of East and West, and where tradition meets innovation. So it's rightly poised to host these discussions and dialogue. So today we have a enriched session with 9 speakers. In the first half, we'll have 4 speakers, then we'll have 20 minutes of break. It's just empathetic that we have a short break to replenish our minds and body. And then in the second half, we have about 5 speakers. Each speaker will bring a different perspective, mostly from global landscape. Though the perspective will be different, but I think the ethos will be a shared commitment for upholding empathy as a professional virtue. So this is not merely a panel, neither a discussion nor a debate, but it's a commitment that all of us come together collectively to recognize the professional identity, including empathy as a central echoic theme. And this declaration will incorporate 5 domains. So within all the speakers, we'll generally see the domains of personal and professional commitment, leadership and team culture, reflection and moral growth, changing world and systemic context, and clinical relationships with focus on adverse outcomes. These are not really aspirations, but our responsibility and our commitment to the society as surgical fraternity whole. So I thank ICS, our distinguished speakers, all the participants who have gathered here today to mark this milestone event. So let's begin this session with open mind, open hearts, and a shared commitment to shaping the surgical future. So let's begin the session. With that, let me invite Prof. London Hui to give us the first talk, and he'll be speaking on surgery beyond what we are paid to do. Prof doesn't need an introduction. He's a past president of Asian Surgical Association. 15 years ago, I was his registrar, and he is locally recognized a key opinion leader in surgery, surgical education and training. And he is an active member of all parts of surgical profession, maybe academic, maybe clinical, maybe education, training or research. With that, Prof, over to you for your session on what we are paid to do. Thank you.
Thanks for the kind introduction. I see some old friends here. Welcome in Singapore. Good to see you again. So Michelle asked me to share with you something about empathy, and I pondered for some time about this because I see many senior surgeons in the audience, and it's hard to remind ourselves where we're headed in terms of how we see our patients and how we see our trainees. So the title I chose was Surgery Beyond What We Are Paid to Do. So my background, I'm a surgeon, HPB and surgical oncology, but I have recently taken on 2 new roles, international collaboration as well as global health. I'm director of Singapore and US Global Health Institute. So that puts into perspective where surgeons should be in the global health scene. This is Max Torres, as you know, from ICS, and he founded ICS based on the following principles. And I put it up here as a reminder about what it means to be empathetic in our surgical practice. So I won't quote his quote on why he founded ICS in 1935, but it's still imperative for us to reflect back on how it started as original ICS. Now, we all came to medicine for a reason, and if you ask any medical student, I'm also dean for admissions in medical school, and when we ask aspiring medical students why do medicine, it's always the same thing. I want to help others, I want to save lives. But then over time, it can be conflicted with other things that come into play. Of course, an income is a hygiene factor that you must think about. But when it overclouds your judgment and so on, it then becomes a problem for us if we are not going to be empathetic to our patients, but looking at finances as the end product for our practice. Now, as surgeons, this is a stereotypical surgeon from my younger days. I know surgeons now just are very nice and to their trainees, they don't scream and shout anymore. But in the old days, this is typical of a stereotypical surgeon. And in this kind of context, to a patient, it's very intimidating. If your patient seeing someone like this, you won't be asking questions, you won't be interacting. So the element of empathy is not seen from surgeon to patient in the true sense in our local practice. Now, ACGME obviously in the US has started putting empathy into their training program. And it's a requirement under 2 aspects, interpersonal and communication skills and professionalism. In those days, we had this thing called the target scan. And that was very early on in the process of development for PNETs. So there was an unknown diagnosis regarding highlighting of a PNET on the target scan, whether it's functional, physiological, or whether it's tumor. We went to tumor board, we went through everything, and because this guy was a high-profile millionaire from Malaysia, he actually was a journalist who was trying to stir up issues in Singapore courts.
Nor there is any legal requirement or ceremonial process. The legitimacy of the declaration itself will come from the international nature of this meeting, the multinational composition of the speakers, the transparent articulation of the principles, and the publication that may follow into international surgery or any other forum that may be determined by the leadership. Organizations may later endorse it formally, and that option remains open to them. But the declaration is born today. And this declaration is about professional empathy for surgeons by surgeons. So on behalf of the ICS and the organizing committee, I declare the session closed and the declaration is inaugurated. Thank you for your participation and your presence. Thank you.
One thing, we need to create a clinical learning environment in the institution and start taking care of your nurses, the residents, the physicians, and the leaders, everybody. Welfare. I think somebody mentioned welfare as a patch. It's not a patch. It's what we discussed everything today here. That's the welfare and well-being of your employees. About the AI, a lot of people have mentioned AI. It's called artificial intelligence. But ultimately it has to be human intelligence. It will be I intelligence. So I think we need to pay attention. It will be integrated into the system, but ultimately we have to become intelligent to use that artificial intelligence. Otherwise, it will be a failure.
Yeah, so the buzzword for that now is artificial wisdom. So you use AI, but you put your own mind to the matter and use AI to assist. So some people call that as artificial wisdom. So if there is no other matter, there are 2 or 3 things. Before I give my closing remark, I'll just request all the faculty to stay around and all the participants to stay around. We may take a group photo later on. There are certificates for all the speakers as well. So having said that, I think we have spent last 4 or 5 hours speaking and discussing matters related to professional empathy.
And we have actually recognized that it's not only a moral imperative, but it's also shaping the professional identity as well as redefining the system level responsibility we all surgeons have. So this declaration will become official when it's publicly presented and adopted by the convening bodies and disseminated. So today's session constitutes that adoption. I think Max and the ICS team would have circulated the declaration draft to all the membership, global representative and membership, as well as all federations of the ICS across 110 nations. And today's session constitutes that adoption. So there is no requirement for us to do signatures, nor there is any legal requirement or ceremonial process. The legitimacy of the declaration itself will come from the international nature of this meeting, the multinational composition of the speakers, the transparent articulation of the principles, and the publication that may follow into international surgery or any other forum that may be determined by the leadership. Organizations may later endorse it formally, and the adoption remains open to them. But the declaration is born today, and this declaration is about professional empathy for surgeons by surgeons. So on behalf of the ICS and the organizing committee, I declare the session closed and the declaration is inaugurated. Thank you for your participation and your presence. Thank you. Prof. Tharum, can I invite you to give the certificates to all of our speakers? So first speaker is Prof. London Wui. Can I invite Prof. Wui on the stage or close by so can have a certificate?
Hãy subscribe cho kênh Ghiền Mì Gõ để không bỏ lỡ